laying on the floor during the MRT. So on the triage form, and then every shift it shows up on the triage form or either on our heart. But if we needed to document it at a different time, this is where we would document. This is what the screening looks like when we open it up. So most times we're doing the screening now when we're supposed to, it's just not containing all the accurate information that it needs to contain. Or we're not documenting what their suspected infection is. With the screening, it's not to diagnose the patient, it's just to state the facts of what's going on with the patient. They may or may not be septic, but include everything that's abnormal so that the doctors or we as nurses can consider that as a possibility. So if they come in with a cough or abdominal pain, make sure we choose that, whatever their complaint is. On other, you can free text. So if they have a complaint that's not listed, you can type it in. If they have a diagnosis, you can put diagnosis pneumonia or whatnot. For the sears, make sure we include everything that's abnormal. 9 times out of 10, there's like 3 or 4 things, and only 1 or 2 may be checked. So it's not as accurate as it should be. So that's what most of the fallout is for the screenings. Same thing with the organ dysfunction. Make sure that we include everything that's abnormal. That's acute. So if they're on Coumadin, don't worry about the INR because, of course, it's going to be higher than 1.5. Same thing for the renal patients. Their creatinine is going to be elevated, so don't include that. For the lactate, it has 2, but we use milligrams per deciliter, so you'll see 18. Okay, so if it's not above 18, don't choose lactate. Okay, because 2 is equivalent to 18 and 4 is equivalent to 36, except for the offsites. Y'all's is in millimoles. So you do see the 2 and 4. And then the interventions. So I know y'all see the alerts that pop up. There's a SEERS alert and a sepsis alert. If you see the SEERS alert, it means that it's picked up on SEERS only. The inflammatory responses, the heart rate, the white blood count, the respirations, the temperature. If it's a sepsis alert, it's picked up on SEERS plus the organ dysfunction. Okay. On the alert itself, it says what date and time and what they picked up. It wants you to do a new screening because those things may not be what's going on with the patient anymore. So when you do your screening, because the alert came up, document what's going on right then. Okay? So their heart rate and respirations may not be elevated anymore, or it may be different things that's abnormal. If you document an intervention, it should take the alert away. If it doesn't, and it's still popping up every time you open the chart, email me or let your managers know the account number so that I can look into it. Because once you document intervention, it should take the alert away for 24 to 48 hours. Okay? Any questions about screenings? No? Okay. We're going to talk about the new protocol. And understanding the different stages or progression of sepsis. So sepsis is when the patient has an irregular response to an infection. So their whole body is beginning to respond to the infection. It's no longer localized. So that's why you see the inflammatory response. It has to be related to an infection. So if they don't have an infection or suspected infection, and you see the elevated heart rate or white blood count, it's not related to sepsis. And that's when it's important to make sure your screening is accurate. Okay. If we don't intervene timely and appropriate, they will continue to progressively get worse, and the mortality will go up, and their prognosis is very poor. They can die if we don't intervene quickly. So again, the SEERS is the inflammatory response that the patient has. Make sure you sign in that the patient has related to an infection. And then the organ dysfunction. So if we don't do something when they start having the inflammatory response, they'll progress to organ dysfunction. So these are the different SEERS and organ dysfunction. So they have an infection or suspected infection, and they start with SEERS. They have to have 2 or more of these. And that's when we would initiate the 3-hour bundle. If we don't, they can progressively get worse to organ dysfunction. Okay? If they have SEERS, organ dysfunction, plus a low blood pressure, that's when we would call the code CERT. SER, sepsis emergency response, only with the low blood pressure. Because those patients are the sickest, they need to have everything done within an hour, not 3 hours, okay? So the code is just so that the lab can go ahead and come and draw our lab work for us. You can have additional hands to help you with the patient if you need it, so that we can get everything done within an hour. So for the MRTs, the 4-cause MRT, you go up, you assess the patient. If you think they're septic with sears and low blood pressure, then you would call the code SERV in, okay, and give the fluid bolus of 30 milliliters per kilogram. If their blood pressure doesn't come up and they have to go to the unit for vasopressors, that's when they go to septic shock. So that's kind of what we just talked about. So it's just a progression. They start with sepsis or simple sepsis. They move to severe with hypoperfusion, and then to septic shock. Any questions about the different stages? So this is our bundles. The 3 hour starts for the emergency room when they come through the front door. Okay. So if they come in and then in triage or either in the emergency room, they're identified with sepsis, then their time 0 started when they came in. So the triage screen is real important, because if you're already picking up on sears, you want to go ahead and at least get some lab work or something done for that patient. Because they need a lactate level, blood cultures ×2, and antibiotics within the first 3 hours. If they have a low blood pressure or lactic acid above 36 or 4, you would give the fluid bolus as well, started in the first 3 hours. And then 6 hours would be, we need our second lactate by that time. And if they're going to have vasopressors, it has to be started before that time. So that's why it's important that we give the bolus in the first 3 hours, because we have to reassess them 1 hour after in order to apply the vasopressors. So if the patient comes in and they screen and they meet criteria for simple sepsis or severe sepsis, but this one is talking about just simple sepsis, you would go ahead and initiate the protocol that would include the CBC, lactic, and blood cultures. Okay, it's an order set that already has those things pre-checked, so you don't have to worry about what you're supposed to order. It's already pre-checked. This is the algorithm that's attached to the policy. Patient shows criteria for severe sepsis or septic shock. Make sure it's documented in the sepsis screening, and then initiate the 3 to 6 hour bundle. That would contain the lactic, blood cultures, antibiotics, and fluid if you need it. The fluid is on the order set, and you would just choose that if it's appropriate for the patient. Put the weight in, it'll calculate it for you. And then recheck the lactic level, it's above 2 or 18, and then start vasopressors if needed. So again, we would call the code SIR if they have severe sepsis with hypoperfusion, meaning they have a low blood pressure. That's it. If they don't have the low blood pressure, then you don't call the code. Or same thing for MRT. If it's a septic patient and they don't have a low blood pressure, then you don't call it. So the protocol is the same as far as if they meet sepsis or severe sepsis. The only difference is if they meet severe sepsis and they're not already on an antibiotic, you can order a one-time dose of Zosyn and vancomycin. So if you're responding to MRT and the patient meets criteria for severe sepsis, then you could, and they're not on antibiotic, then you could go ahead and give them a one-time dose while you're waiting on the physician to call to get a scheduled antibiotic. These antibiotics are overridable on all the floors too. And then the fluid bolus. So the antibiotics and fluid bolus would be for the codes. Okay. Any questions so far? This is that handoff sheet that we're supposed to be using, that's orange or yellow, to show if a code was called, what time and date, if the MRT was called, what time and date, the time and date that the lactate and blood cultures are drawn, the antibiotic was given, and if a fluid bolus was given. So it's only for patients that are going to be admitted. So if they're going to go home, you don't have to do the sheet. If it's a new MRT, then the sheet, should be with it. It's so that the next nurse can know what's been done without having to dig through the computer to find out. So they can quickly look to see, did we meet our requirements? And has the second lactate been drawn if needed? On the back of the sheet is a nurse pathway for sepsis. So what would distinguish what criteria and what you would do based on that criteria. Oops. Again, that's talking about the code. So the ones I skipped over was for the IMC med-surg units. So the triage and ED are most important as far as first identifying the patients, because over 85% of the patients come through the emergency room. So if they make it through the emergency room, we do them on the admission and every shift, and if condition changes, because if they get to the floor and they start to deteriorate, that's when they're most likely to end up in the unit, because they'll deteriorate very quickly. So usually when they come into the emergency room, they're just simple sepsis. So if we potentially intervene at that point, they won't progress to get worse to need an MRT or a code. This is a call script that's attached to the policy and on all the units to help the nurses communicate with the physicians as far as if they're concerned about sepsis or if they meet criteria for the sepsis screening. So they can make sure that they address all the different metrics with the physicians. So to order the protocol, you just go to inpatient summary and then click on shared, my plan favorites, and then you would choose based on whatever department you're in. So it's different than just typing in sepsis in the order, because this one is specific for our hospital. It already has those pre-checked things according to our protocol. So the ED one, the offsite, is how y'all order lab versus the just regular ED protocol, and then the inpatient. So the difference between them really won't matter too much to you, but as far as physician-wise, if they do the ED protocol, it only contains antibiotics for a one-time dose, where the inpatient will have it scheduled based on whatever infection source they choose. So that's why there's 3 different ones. You would just click order and then sign. You would put either the ED physician's name or the attending and do protocol authentication required. So all the physicians know about this. It's been to NBC governing board, so they're all on board. They all agree. They help to write the protocol. Okay, a representative from all the departments. So if you have any pushback from them, let me know. Okay, so we can talk to them. They may not be aware of it if it wasn't communicated to the departments. So we're going to go over 3 case studies. Do y'all have any questions so far? These are all patients that's come through our hospital. So the first one is an 80-year-old male that was a direct admit for a necrotic right BKA that he had just had 6 weeks prior. His history is diabetes, hypertension, peripheral artery disease, peripheral vascular disease. His lab work when he got to the floor was temp 98.3, heart rate 94, respirations 18, blood pressure 129/66, pulse ox was 100, and white blood count was 7.2. So when he got to the floor, does he meet criteria for sepsis? No. Why? Huh? He only has 1 Sears, is his heart rate. And remember, we have to have 2. So the day after admission, he has a revision of his thumb. 2 days after that, there's an MRT call because his blood pressure is 73/49, heart rate's 103, respirations was 24, altered mental status, and his white blood count was 14.1. So does he meet criteria during MRT?
Yes.
Yes. What stage? Severe hypoperfusion. Good. So if we were to document our screening at that time, what would we choose as a suspected infection?
Recent procedure.
Recent procedure. And then what would be our Sears?
Respirations, heart rate,
Respirations,
and
heart rate.
blood pressure.
white blood count, altered mental status. So what would be his organ dysfunction?
Blood
The
pressure.
blood pressure. So what things need to happen at the MRT? What interventions? Fluid,
Fluids.
what else?
Lactics.
Lactic, antibiotics,
Blood
blood cultures. So this patient had not had nothing done by day 3. No antibiotics, no blood culture, no lactic acid, no nothing. So this is why the code is important for certain patients that meet criteria. So in this situation, we would want to order that one-time dose antibiotic. So that's why I kind of did different departments at different times so that the inpatient nurses, when they call MRT, can really know what's expected for them to give to the MRT team when they get there. Has the patient had antibiotics? What procedures have they had done? What's their vital signs been running throughout the day? Because this patient started deteriorating 12 hours before the MRT was called. And then he went to ICU and he expired within 12 hours. So any questions about this case study? So this one kind of shows the importance of our code and why we're going to start it. So the second one is a 70-year-old female came from home to the ED with worsening upper mental status, fever, weakness, wound on the legs. Patient was admitted to med-surg with diagnosis of fever, sepsis, and wound infection. History is CHF, blind, diabetes, and dementia. So when they were in the ED, they already went through triage, and they're in the ED, they had lab work. So their heart rate's 86, blood pressure is 158/78, respiration's 18, temp 98, white blood count is 20.2, and lactic acid is 23.4. So in the ED, do they meet criteria for sepsis? Yes. So what would we document as a suspected infection? Wound. So what would be the SEERS that we would document? White blood count, altered mental status. Even though the dementia is chronic, she's had an acute change. Okay. What would be the organ dysfunction? Lactic. Yes. So what criteria does she meet? She's got 2 SEERS and 1 organ dysfunction. Severe. Does she meet hypoperfusion? No. Would we call a code for this patient? No. But what do we need to make sure is being done? Antibiotic, blood cultures, lactic acid. So they went to the med-surg unit. I'm not sure what day the MRT was called, but the MRT was called on the patient. Heart rate was 107, blood pressure was 116/79, respiration is 18, temp was 103, white blood count is 12, bands is 6, lactic acid is 23.6, and creatinine is 2.7. So during the MRT, does she meet criteria for sepsis? Yes. So what would we document as the suspected infection? Same thing, the wounds. What would be our SEERS at the MRT? Temp, heart rate, white blood count, bands. What would be our organ dysfunction? Creatinine, lactic. So do we need to call a code for this patient at the MRT? No. No low blood pressure. Okay. But we do need to make sure what things have been done or need to do for this patient. So we could tell they had a lactic acid, right? So what else do we need to check during the MRT or as a floor nurse to make sure the patient is getting the appropriate treatment? Antibiotics and blood cultures. Our blood cultures are good for 2 days. So if it's been past 2 days since they had blood cultures and they've had a change in condition where they're worse with sepsis, we need to repeat the blood cultures. Okay. So what new organ dysfunction does she have that would indicate she may be getting worse from sepsis? Creatinine. So that's why it's kind of important that we document everything that is going on with the patient at the time, so that the next screening shows what may have changed or gotten better. Any questions about this patient? I don't know what her outcome was. The other one just kind of stands out to me. This one is a 49-year-old female that came from home to the emergency room with nausea, vomiting, fever, chills, dysuria, and flank pain. History of diabetes. Vital signs at triage was blood pressure 80/40, heart rate 120,
Severe.
respirations 18, temperature 102, and weight is 66. So does she meet criteria at triage?
Yes.
Yes. So what would we document as the suspected infection? Dysuria,
Flank pain.
flank pain, vomiting, nausea, all that. What would we document as sears?
Heart rate.
Heart rate,
Temperature.
temperature. So what's our organ dysfunction?
Blood pressure.
Blood pressure. So do we call a code?
Yes.
Yes. What things do we need to do for this patient? Lactates,
Cultures,
cultures,
antibiotics.
antibiotics,
fluids.
fluid. What's our time?
1 hour.
1 hour, because we're calling a code. Okay? So if the patient doesn't respond to the fluid bolus, if their blood pressure stays low, what category would they move to?
Shock.
So right now, what stage are they in? Because we call the code.
Severe.
Hyperfusion.
Severe with hypoperfusion. Good. Any questions? So again, mortality goes up every hour that we don't give antibiotics and fluids, so that's why our code is important for those patients that are the sickest. So we're gonna watch a little video, it's 12 minutes, about the importance of a code sepsis. While the video's going on, we'll give you a test. If you'll answer the questions on the test, and then we'll go over it after the video. And the sound system in here is messed up, so the sound only comes from the screen. So hopefully you can all hear it. Well, they did fix it.
First is outflow.
They did fix it.
She went in for a simple hemorrhoidectomy
Is that too loud?
on a Thursday. 5 days later, she was gone. To something I had never heard of.
Many death certificates list the cause of death as cancer. Many of those patients die of sepsis. Many death certificates list the cause of death as complications of heart disease, and the cause of death is sepsis. Many death certificates list the cause of death as complications of pneumonia, and the cause of death is sepsis.
According to a recent poll, close to half of all Americans have never heard the word sepsis.
And in fact, I practiced dentistry for 25 years, and I didn't know anything about sepsis.
We have more than 1.6 million cases of sepsis annually in this country. And of those cases, nearly 20% wind up dying.
There's an epidemic that is occurring in sepsis. This has been increasing in the number of cases by about 9% per year. Certain groups of people seem to be at higher risk for sepsis. That includes people like the very young, elderly people, people with chronic conditions like cancer or liver disease. People who are over the age of 65 are 11 times more likely to have a hospitalization associated with sepsis than someone who's less than 65. But there should be no mistake. Sepsis is an equal opportunity killer. It kills the young, it kills the old, it kills the sick, it kills the healthy. Sepsis is really a toxic response to an infection. So your body is constantly inundated with challenges by microorganisms, bacteria, viruses, fungi. And you have an extensive system in your body to try and keep that bacteria from becoming an infection. The problem is that body can also go haywire. And so as a result, instead of protecting you, your body actually starts trying to kill you.
The immune system is mobilized to action like an army, and the white blood cells are firing bullets at the bacteria or at the invaders. And that's fine when the bullets are targeting the bacteria, but it becomes a real problem when the bullets start flying everywhere and you get collateral damage on the patient's own organs, and this becomes a catastrophe.
So you may hear a number of terms that are used in the hospital around sepsis. There's sepsis, severe sepsis, septic shock. Sepsis is at its basic heart this notion of having systemic inflammation due to an infection.
In some instances, sepsis progresses to the point that people's organs fail. When your organs fail or aren't working correctly, this is called severe sepsis. The most serious form of sepsis is when your blood pressure drops as a result. This we call septic shock.
Aaron went in on Thursday for elective surgery, hemorrhoidectomy, just a routine surgery. I had it done before. And on Friday, they dismissed her for the weekend. Well, everything seemed okay until Sunday night, and all of a sudden it had a turn for the worse and the pain level went up. Well, that's completely contrary to a healing phase. So my wife took her back to the hospital. They kept her Sunday night. I went in Monday to see what's going on. And I could tell something was wrong when I could see her blood pressure was off, very low, her heart rate was up. I said, "Where's the doctor?" He said, "Well, he's down there." I said, "Well, go get him." And he walked in, he said, "I think she's septic." It's the first time I heard the word septic. She had the infection when she came home on Friday night, but they did not give antibiotics because they told her they were concerned it would cause diarrhea. So if she would have had the code sepsis that we referred to, that is fluids and antibiotics on a Friday night, this was all preventable. And it's such a shock for that to occur and someone die from something you've never heard of. And that changed my life. I was with her when she died. She looked at me. And said, with her eyes, "Can't you do something about it?"
If doctors treated sepsis as a medical emergency in all instances, as many as 50% of deaths occurring now wouldn't happen. And so that's 125,000 people surviving every year who would have otherwise died.
We think that one of the ways to emphasize the need for treating sepsis like a medical emergency is to refer to this in the same way that we refer to other medical emergencies, which is as a code. If you're in a hospital, you might hear a code blue. That means that there's a team that responds to someone who's hard to stop. We're trying to promote the notion of a code sepsis. And what code sepsis is, take this disease seriously. Suspect it, administer early antibiotics, administer fluids, and get the help you need to provide care for the patient. Reducing mortality in sepsis is as easy as getting antibiotics into patients. What we also know is that your mortality goes up by about 8% for every hour that passes without antibiotics. Unfortunately, there's not a single sign or symptom that really tells you you have sepsis.
But I think there are some warning signs that people can look out for. These can include things like problems breathing, a fast heart rate, either a high temperature or chills, feeling dizzy or lightheaded, particularly when you stand up, and problems with changes in the level of consciousness. And this can include either confusion or possibly being difficult to arouse. If you're concerned about sepsis, one of the things to do is, when you talk to your doctor, say, "I'm worried about sepsis." That cues the doctor to think about this as a problem and do further testing.
The first time I felt the sore throat coming on, it was a Friday night. It was just like a slight soreness in my throat, nothing major. The next morning I woke up and it was the worst sore throat of my life. I actually could barely talk. I was having trouble breathing. I started running a really high temperature. I started throwing up blood. That's when I realized it was time to go to the emergency department.
And at that time, the thought was that she probably just had a viral illness like a cold leading to a sore throat. Over the next couple days, however, she got worse. Had increasing confusion, noticed her skin was mottled and had blue discoloration, and wound up coming to the hospital a second time.
When I was admitted to the ER, they reported that I was already in septic shock. I had H1N1. I was in renal failure.
In Jen's case, her sepsis led to the formation of small blood clots in small blood vessels throughout her body. As a result of that, she didn't get enough blood flow to her extremities. And that led to gangrene, which is tissue dying.
And I do remember looking at my hands and seeing that they were black and they were curled into like a claw because they had died, but not understanding what that meant. And also seeing my feet and toes and they were black.
As a result of that, she required amputations.
I remember my mom coming into my room and saying, "It's time for you to go to your surgery." And I just started crying because I felt like I wasn't going to make it through the surgery. And there was so much I wanted to tell my mom, but I couldn't talk at the time. So I just said, I'm sorry.
It's hard to really understand how sick she was. Her family was called in multiple times to her bedside because the doctors all thought she was gonna die within minutes. And she was as close to death as anyone can be.
It was extremely touch and go for months.
She just slowly started getting better, but it still took her months to recover. The great unknown is the number of people who survive sepsis but are significantly disabled as a result. And those disabilities can be obvious, things like amputations, but they also can be things that are hidden, like problems with thinking, memory, calculations. Some even suffer from post-traumatic stress disorder. We feel happy that they've survived, but they're still carrying scars around with them for the rest of their lives.
Well, I want to share my story because I've always wanted to help people, and I think this is a good way. I've always had that drive, but now it's in me even more. It makes me feel good if just one person knows what sepsis can do and how important it is to get treatment for it immediately so that there aren't grave consequences.
And it all comes down to hope. That is, hope from shared responsibility that an informed public can work with their healthcare providers to reduce the deaths and disability from sepsis. The public will have to be empowered to demand and ask for early treatment. They must show that they're concerned about it, and you always have to have an advocate with you, checking everything is done.
It is possible to improve the treatment and the survival from sepsis in the future. Will we be able to prevent any patient with sepsis from dying? Probably not. But will we be able someday to significantly improve the mortality rate of severe sepsis? Absolutely yes. But we're not there yet. We have a ways to go.
However, this is a disease we can affect today. We don't need new scientific discoveries to reduce the mortality rate by 50%, to cut the number of people dying in half. All this takes is us doing a better job.
Okay, any questions about the video? Okay, we'll go through the test. When are sepsis screenings completed?
B.
B, yes. How many seers must be present for sepsis?
B.
2. How many organ dysfunctions must be present for severe sepsis?
C.
C. Does there have to be a confirmed or suspected infection for sepsis to be present? Yes. Remember, it's it's the body's response to an infection. It's that irregular, that dysregulated response to the infection. What are 2 examples of sears?
Elevated temp and ultrasound stuff.
Yes. Also heart rate, white blood count, bands,
Respiratory.
respirations, glucose if they're not diabetic. So what would be 2 examples of a suspected infection?
Abdominal pain, dysuria.
Abdominal pain, dysuria, vomiting,
Cellulitis.
wounds. If they come in, they have a dialysis catheter that's really nasty looking, that could be our possible source. What are some examples of organ dysfunction?
Elevated creatinine.
Creatinine, lactic acid, blood pressure, bilirubin. If they need oxygen now, and they normally don't use oxygen, that may be organ dysfunction. What is the definition of simple sepsis?
A.
A. Suspected or confirmed infection in 2 or more seers. What is the definition of severe sepsis?
C.
C. Suspected confirmed infection, 2 or more seers, 1 or more organ dysfunction. So what is severe sepsis with hypoperfusion? C. When they have that low blood pressure, or their lactic acid above 36. When do you call a code sir? B. If their blood pressure is low. What amount of fluid bolus is given? C. 30 milligrams. It should be milliliters. Oh, I think I corrected on y'all. Per kilogram. When is the fluid bolus given?
B.
B. Only with hypoperfusion, the low blood pressure, or the lactic acid above 36. but we only call it code CER for the blood pressure, not for the lactic acid. We just give the fluid bolus. Who can order, what is septic shock? D, both B and C. When their lactic's above 36, or we give them a fluid bolus for their blood pressure, it doesn't come up. Who can order the 3 and 6 hour bundle protocol? C, nurses and doctors. What is completed in 3 hours? B, lactic level, blood culture, antibiotics, and fluid if needed. When should the second lactate be drawn? C, in 3 hours. And you know that if the lactate's elevated, the system will automatically reorder the next one.
Reflex.
Yes. Any questions about anything? That's all I have.
Thank you.
Thank you. Just leave your tests in the folders and I pick them up.